If you've been prescribed Amlodipine, Losartan, or Lisinopril to manage your blood pressure, there is a strong chance that at least one thing happening inside your body right now is connected to that medication. And you may be attributing it to something else entirely. Old age, stress, poor sleep, a cold that won't fully clear, the wrong food. But the real explanation has been sitting in your pill bottle every single morning. This is not about fear. This is about the specific knowledge that separates the patients who manage these medications safely for years from the ones who quietly run into serious problems because nobody connected the dots in time. Before we go further, please subscribe to this channel so you never miss health information that is designed to protect you rather than overwhelm you. I am Dr. Olivia Carter, and today I want to walk you through 11 things that anyone taking these 3 blood pressure medications needs to understand. Not because the medications are dangerous when properly managed, but because proper management requires information that too many patients simply never receive. Let me begin with Margaret. Margaret was 74 years old, methodical, conscientious, the kind of patient who never missed an appointment and kept a written record of every medication she had ever taken. Her blood pressure readings had improved significantly since starting her prescription. Everything on the chart looked the way her doctors wanted it to look. But at home, something had been changing for weeks that Margaret had not mentioned to anyone because she had not connected it to the medication. By early evening, her feet no longer fit comfortably inside her shoes. Her ankles were visibly swollen by the time she sat down for dinner. She assumed she was retaining water. Her family wondered whether her heart was beginning to fail. She was frightened, quietly, every single day, and she carried that fear alone. What nobody had explained to Margaret was that the medication keeping her blood pressure numbers beautiful was also the direct cause of what was happening to her legs. And understanding that difference between something alarming and something explainable is exactly what this video is going to give you. Number 11. These 3 medications are not the same drug wearing different names. This matters more than most patients realize. Amlodipine belongs to a class called calcium channel blockers. Losartan belongs to a class called ARBS, which stands for angiotensin receptor blockers. Lisinopril belongs to a class called ACE inhibitors. They all accomplish the same broad goal of reducing blood pressure. But the pathway each one uses is completely different, which means the side effects each one produces follow completely different patterns. If you treat them as interchangeable, you will consistently misread what your body is telling you. Amlodipine works primarily by relaxing the walls of blood vessels. Lisinopril reduces the production of a hormone that constricts those vessels. Losartan blocks that hormone from attaching to its target. Same destination, 3 entirely different routes. When you understand which route your medication is using, symptoms that seemed random suddenly become readable. A cough that appears 2 months after starting treatment is not a mystery when you know that ACE inhibitors have a well-documented mechanism for producing exactly that kind of cough. Leg swelling that develops gradually is not a heart problem when you understand how calcium channel blockers alter fluid dynamics in the lower extremities. Knowing the class of drug in your prescription is not medical trivia. It is the foundation of being a safe and informed patient. Number 10, Amlodipine and the swelling that fools everyone. This is what was happening to Margaret, and it is one of the most commonly misunderstood side effects in cardiovascular medicine. When amlodipine relaxes blood vessels, it tends to relax the small arteries feeding blood into the legs and feet more aggressively than it relaxes the veins responsible for carrying that blood back up. The result is an imbalance. Blood flows in more easily than it flows out. Fluid pressure builds in the tiny capillaries, and that fluid gradually leaks into the surrounding tissue. The ankles and feet swell. And the pattern is distinct. Most people feel fine when they wake up. The swelling appears and worsens as the day goes on, and you spend more time upright. By evening, the puffiness can be significant enough to leave indentations in the skin where socks or shoes have pressed. Consider what happened with Donald. Donald was 79 years old and noticed his legs felt heavy and looked different every afternoon. He assumed it was his circulation deteriorating with age, something inevitable that he simply had to accept. He started sleeping with a pillow under his feet and noticed some improvement overnight, which seemed to confirm his suspicion that it was a circulation problem rather than anything to do with medication. He had been on amlodipine for 2 months at that point. The swelling is not automatically a reason to stop the medication. That is a decision that requires medical assessment. But it is absolutely a reason to have a specific, direct conversation with your doctor. The danger Donald experienced was not physical harm from the swelling itself. The danger was the silence around it. When you do not report what is happening, the people responsible for your care cannot make the adjustments that might resolve the problem without disrupting your blood pressure management. Number 9, Lisinopril and the cough that arrives uninvited. This particular side effect is well known enough within medical practice that it has become almost a teaching tool for pharmacy students. But that knowledge has not translated into adequate warning for the patients actually experiencing it. Lisinopril produces a dry, nagging, persistent cough in a meaningful percentage of patients who take it. The mechanism involves the accumulation of a substance called bradykinin in the airways, which the ACE inhibitor pathway allows to build up rather than breaking it down as it normally would. The result is an irritation in the throat and airways that produces a cough that is not wet, not productive, not associated with congestion, and stubbornly resistant to every remedy a person tries. What makes this side effect particularly confusing is the timing. The cough does not always begin immediately. Some patients develop it within days of starting the medication. Others do not notice it for weeks. And in some cases, the cough appears months after the prescription began, by which point the patient has long stopped thinking about the medication as a possible cause. Patricia had been on lisinopril for nearly 5 months when she developed what she described as a tickle in the back of her throat that gradually became a nightly ordeal. She tried antihistamines. She replaced her bedroom pillow. She bought a humidifier. She saw her primary care doctor about possible reflux. She tried acid-reducing medication. None of it helped because none of it addressed the actual cause. The cough was the lisinopril, doing what a percentage of lisinopril prescriptions inevitably do. And the late onset had hidden the connection completely. Here is the critical distinction that everyone on an ACE inhibitor must understand. A persistent dry cough is an expected and manageable side effect that warrants a conversation. It may lead to a medication change. It does not mean you are in immediate danger. But swelling in the lips, the tongue, the face, or the throat is categorically different. That symptom pattern, which can occur rarely with ACE inhibitors, is called angioedema, and it can progress to a life-threatening emergency very quickly. That is not a symptom that waits for your next scheduled appointment. That is a symptom that requires immediate emergency care. The cough, understand and report. Swelling of the face or throat, act immediately without hesitation. Number 8, potassium is not just a supplement concern. It is a medication safety issue. Both lisinopril and losartan influence the body's ability to regulate potassium levels, and they can cause potassium to accumulate in the blood over time. Most patients hear this and think, I do not take potassium pills, so this does not apply to me. That reasoning is dangerously incomplete. Because potassium does not only arrive through supplements, it arrives through food and through products that most people do not think of as potassium sources. Salt substitutes are the most significant hidden risk in this category. Many of the products marketed for heart health that replace sodium with an alternative use potassium chloride as that replacement. If you are avoiding regular table salt and using a heart-healthy seasoning blend or a low-sodium salt product, there is a strong possibility you are adding meaningful amounts of potassium to every meal. Combine that with a medication that slows the kidney's ability to eliminate potassium, and the levels in your blood can rise into a range that begins affecting the electrical system of your heart. Richard was 76 years old, genuinely committed to protecting his cardiovascular health, and proud of the dietary changes he had made. He had reduced his sodium carefully and switched to a salt substitute his pharmacist had recommended as heart healthy. He had no way of knowing that this combination, Losartan plus a potassium-based seasoning used multiple times daily was quietly pushing his potassium levels upward. He began to notice muscle weakness in his legs and what he described as an irregular fluttering sensation in his chest that came and went. When his labs were checked, his potassium was elevated enough to require prompt medical attention. Richard had done nothing wrong by any standard he had been given. The gap was in the information he never received. Before you add anything to your diet that carries a health claim and replaces sodium, verify that it does not use potassium as the replacement, especially if you take Losartan or Lisinopril. Number 7, the kidney conversation that confuses and frightens patients unnecessarily. Losartan and Lisinopril are prescribed for reasons that extend beyond blood pressure alone. In patients with diabetes, early kidney disease, or heart failure, these medications have demonstrated protective effects on kidney function over time. But when a doctor draws blood shortly after starting one of these medications, and the report shows a change in kidney function numbers, a rise in creatinine, a shift in the eGFR figure, patients frequently interpret this as the medication harming their kidneys. That interpretation, without more context, can lead to a decision that actually removes a protection that was helping. A small early shift in kidney function markers after starting an ACE inhibitor, or ARB, is sometimes an expected physiological response to the way these medications alter pressure dynamics within the kidney's filtering system. Whether that shift is acceptable and expected, or whether it represents a genuine cause for concern, depends entirely on how large the change is, whether it continues to progress, and what else is happening clinically. That determination cannot be made by reading a number on a patient portal without medical context. Sandra was 68 years old and had both hypertension and early-stage kidney disease. Her physician had chosen Lisinopril specifically because the evidence supported its protective role for her kidneys long-term. 2 weeks after starting it, her lab results showed a change. She saw the numbers before any clinical staff had called her. By the evening, she had convinced herself the medication was destroying her kidneys, and she was close to stopping it entirely on her own. When she spoke with her doctor, the explanation that followed transformed her understanding completely. The key question, she was told, was not whether the number had moved. The key questions were how much it moved, whether it was stabilizing, and whether the overall clinical picture supported continuing. Lab monitoring is not a bureaucratic formality with these medications. It is an integral component of using them safely. Number 6, what illness does to your blood pressure medication. This is one of the most practically important and least communicated aspects of managing these drugs. Losartan and Lisinopril interact with the body's fluid balance in ways that become significant when that fluid balance changes. Under normal circumstances, the medication is calibrated for a body in a normal state of hydration. But when vomiting, diarrhea, prolonged poor appetite, or significant sweating changes your fluid status, the same dose of medication that was appropriate yesterday may produce dramatically different effects today. Blood pressure can fall too low. The kidneys can experience stress. Dizziness, extreme weakness, and in serious cases, acute kidney injury can develop faster than people expect. Frederick was 78 years old and had never missed a dose of his Losartan in the time he had been prescribed it. When a gastrointestinal illness left him unable to keep meals down for 2 days, he continued his medication precisely because he took compliance seriously. By the second night, he stood up from a chair and nearly fell. In the emergency department, his blood pressure had dropped significantly, and his kidney values had shifted in a way that required attention. The Losartan had not failed him. The clinical assumption built into his prescription that he would be normally hydrated no longer applied. What Frederick needed was a sick day protocol, a set of simple instructions about what to do when illness changes the body's landscape. This is not an uncommon situation. It is predictable, and preparation for it prevents outcomes that are avoidable. Number 5, the pain relief problem that surprises almost everyone. There is a combination of medications sitting in countless medicine cabinets that most patients do not recognize as potentially dangerous because each component seems perfectly ordinary on its own. Lisinopril or Losartan, often alongside a diuretic prescribed for blood pressure or fluid management, combined with regular use of over-the-counter anti-inflammatory pain medications like ibuprofen or naproxen. Each of these is familiar. Each has been available for decades. None carries an obvious warning in the patient's mind. But together, particularly in the context of inadequate hydration, they can significantly reduce blood flow through the kidneys and increase the risk of kidney injury. Catherine was 71 years old and had managed her arthritis with over-the-counter anti-inflammatory medication for years before her blood pressure required treatment. She did not think of the pain medication as something to mention when her cardiovascular prescriptions were being written, partly because she had been using it so routinely, it felt like a background feature of her life rather than an active medication. When her lab results began showing declining kidney function and her blood pressure became more difficult to control, the interaction between her prescriptions and her pain management routine was the explanation. Once the anti-inflammatory was replaced with a safer alternative and her monitoring was adjusted, the situation stabilized. But the path to that understanding had taken longer than it should have. If you take Losartan or Lisinopril, over-the-counter pain relief is not a casual topic. It belongs explicitly in every conversation you have with anyone managing your medications. Number 4, dizziness is not always minor, and in older adults, it is never something to simply dismiss. All three of these medications can produce dizziness, particularly when treatment is first started or when the dose is increased. The mechanism is direct. Blood pressure has been lowered, and the body's circulatory system takes time to adapt to that new baseline, especially when changing positions. Moving from lying down to sitting or from sitting to standing can temporarily outpace the body's compensatory response and produce a sensation ranging from mild lightheadedness to a more significant spinning or loss of equilibrium. In the younger adult, a few seconds of lightheadedness after standing up quickly is an inconvenience. In a 75-year-old living alone, it is a potential fracture, a head injury, or a serious fall. Joseph was 81 years old when his dose of amlodipine was increased. 2 nights later, he rose to use the bathroom, and the room tilted so completely that he grabbed the door frame to avoid falling. He did not fall, but the near fall frightened him enough to stop taking the medication entirely without telling his doctor, which resulted in his blood pressure rising to a level that created its own serious risk. What he had needed was preparation, a concrete description of what the medication might feel like during the adjustment period, and specific practical guidance about how to rise slowly, pause at the edge of the bed, and give his body time to stabilize before moving. That preparation takes 2 minutes to deliver. The absence of it can take much longer to recover from. Number 3, single blood pressure readings are not verdicts. They are snapshots in a moving picture. Blood pressure responds to dozens of variables in the course of any given day. The quality of the previous night's sleep, whether caffeine was consumed, the level of anxiety in the room at the time of measurement, pain or discomfort, the position of the body, whether conversation was happening during the reading, and even the stress of worrying about what the reading will show. A single elevated number taken in the wrong context does not mean your medication has stopped working. A single low number does not mean your dose is too high. What matters is the pattern across consistent conditions over time. Diane was 69 years old and had developed a measurement habit that had gradually taken over a significant portion of her day. She checked her blood pressure whenever she felt anxious or unwell. When the reading was elevated, she checked again immediately, then again, and often several more times, generating a page of numbers that created the impression of a serious, uncontrolled problem. She was convinced her lisinopril was failing. When her monitoring approach was replaced with a structured protocol, same time each day, 5 minutes of seated rest beforehand, no conversation during measurement, the picture that emerged was entirely different from the one she had constructed through anxious repetition. The medication was performing appropriately. The measurement approach had been producing misleading data that was driving unnecessary fear and eventually impulsive decisions about doses that her doctor had never authorized. Number 2, consistency is treatment. Inconsistency is risk. Blood pressure medications in this class are designed to maintain a stable level of effect through reliable daily dosing. They are not acute rescue medications. They do not respond to a single high reading by producing an immediate correction. They work by sustaining a consistent pharmacological environment over time. When that consistency is disrupted, through missed doses taken at irregular makeup times, through doubling up after a forgotten dose out of anxiety, or through skipping doses without medical guidance, the treatment environment becomes unstable in ways that can produce exactly the outcomes the medication was prescribed to prevent. Martin was 73 years old and had developed an informal approach to his lisinopril schedule that felt responsible to him but was creating an inconsistent medication pattern. On mornings when he forgot his dose, he would take it whenever he remembered, sometimes in the afternoon, sometimes at dinner. On evenings when his home blood pressure monitor showed an elevated reading, he occasionally took an additional tablet on the reasoning that his pressure clearly needed more management. After one such evening, he spent the following day feeling profoundly weak and unsteady, with a blood pressure that had dropped far below his usual range. The medication had accumulated beyond its intended level. He had not been reckless. He had been operating on incomplete information about how this category of drug actually works. The solution was straightforward: a clear, specific set of instructions about what to do when a dose is missed, written down, reviewed at the appointment, and available to consult in the moment rather than recalled under the pressure of anxiety. And number 1, the medication that appears to be working on paper may be failing the person taking it. This is the most important and most underappreciated truth in long-term blood pressure management. Measuring success only through the numbers on a blood pressure chart misses half the picture. A medication can produce beautiful readings while simultaneously making the patient's daily life significantly worse through side effects they are enduring silently, symptoms they are normalizing out of compliance, or discomfort they have stopped reporting because they assume it is simply the cost of treatment. When patients stop tolerating their medication but do not feel empowered to say so, a predictable sequence unfolds. First comes resentment of the pill. Then comes forgetting to take it, often on some level intentionally. Then comes selective skipping. Then comes stopping entirely. Then comes the clinical team's confusion about why the blood pressure is suddenly uncontrolled again. Teresa had been on lisinopril for just over a year, and her numbers were consistently in the range her cardiologist was looking for. But Teresa had been coughing every night for 11 months. She was exhausted. She dreaded going to bed. She had told no one because she assumed that expressing difficulty would result in being told to push through it for the sake of her heart. That assumption was costing her sleep, her energy, and gradually her willingness to continue treatment. When the cough was finally identified and attributed to the medication, a reassessment revealed that an alternative could potentially provide the same cardiovascular protection without the ACE inhibitor mechanism responsible for her cough. The cough did not mean the medication class had failed. It meant the specific pathway was not compatible with her physiology. That is information, manageable, actionable information that required nothing more than the conversation Teresa had been afraid to initiate. Here is the practical framework to carry with you. If you take amlodipine, pay attention to leg and ankle swelling that worsens through the day and improves overnight. Monitor for dizziness when changing positions, and report any persistent headaches during the adjustment period. If you take lisinopril, watch for the dry, persistent cough. Note any dizziness, particularly in the first weeks, and understand clearly that swelling of the lips, tongue, or throat is an emergency requiring immediate care rather than monitoring. If you take Losartan, be aware of dizziness. Watch for signs of elevated potassium, including unusual muscle weakness or irregular heartbeat. Review anything you use to replace salt in your diet, and follow the sick day guidance your doctor provides, rather than continuing your normal dose through significant illness. For both Losartan and Lisinopril, lab monitoring is not optional. It is part of the treatment itself. And for all three medications, the symptom you cannot explain is worth discussing. You do not need to be certain that it is connected to your medication. You need only to have noticed a pattern that concerns you. The distinction between a side effect that may resolve with time and one that requires immediate intervention often cannot be made without clinical input. Your job is to notice and report. The interpretation belongs to the people trained to provide it. The patients who manage these medications most successfully over time are not the ones who push through every difficulty in silence. They are the ones who understand what the medication is doing, know what symptoms fit the expected pattern and what symptoms fall outside it, maintain consistent habits around their dosing, bring their questions to their appointments before they become decisions made alone, and understand that reporting a side effect is not complaining. It is providing the information that allows your medical team to do their job properly. The knowledge gap around blood pressure medication is not a failure of medicine. It is a failure of time. Appointments are short, information is dense. Patients leave with a prescription and a general understanding that something serious was found, and this is how it is being addressed. But the specific details, the class of drug, the mechanism, the symptom patterns, the interactions, the monitoring requirements, the sick day adjustments, the timing principles, those details often fall away in the rush of a brief consultation. This video exists to fill that gap. If any of this information has clarified something you have been wondering about or helped you recognize a symptom you had been attributing to the wrong cause, share it with someone you know who is managing blood pressure medication. The information that reaches them today might prevent the urgent call that would otherwise come 6 months from now. And when questions arise, bring them to your doctor or pharmacist, not after you have already made a decision, before. That is where the safety is. That is where the best outcomes are built.